Welcome to The Explainer. Today, we're diving into the first 15 minutes of a stroke. In that total chaos, how do doctors even begin to make sense of it all? Well, they use a special neurological toolkit, a kind of standardized language that gives them a rapid snapshot of exactly what's happening inside the brain.
It seems like an impossible question, doesn't it? How do you measure something like that? But it turns out there's a remarkably effective and standardized way to quickly assess the damage, to, in a sense, put a number on the chaos.
And it all boils down to a scale that goes up to this number, 42. This represents the most severe stroke you can imagine. Every single point on this scale is a crucial piece of the puzzle, guiding doctors in that absolute race against time.
So, let's break it down. At its very core, a stroke is a brain injury. It happens when the blood supply to part of your brain gets cut off or seriously reduced. That means brain tissue isn't getting the oxygen and nutrients it desperately needs, and we're talking minutes here. Brain cells start dying almost immediately, which is why time is everything.
Okay, so broadly speaking, strokes come in two main flavors. You've got your ischemic stroke, which is the most common one. Think of it like a plumbing problem, a blockage, a clot. Then you have a hemorrhagic stroke. That's not a blockage, it's a leak, a blood vessel that's actually burst. Figuring out which one is happening is, you guessed it, step one for diagnosis and treatment.
So how do doctors figure all this out so quickly? This is where the NIH Stroke Scale, or NIHSS for short, comes into play. You should think of it less like a simple scale and more like a rapid 11-step neurological exam that gives them a full snapshot of the stroke's impact.
So this toolkit, it's not just one thing. It's a whole series of checks that systematically test a brain's functions one by one to literally map out the damage.
First up, they have to establish a baseline. The most fundamental thing. What's the patient's level of consciousness? Are they awake? Can they respond to you? This basic check really anchors the entire assessment.
Next up, a simple eye test. And you know, when a doctor asks a patient to follow their finger, they're doing way more than just checking their vision. They're directly testing specific cranial nerves that control all those tiny muscles that move our eyes. If the eyes can't track together, that is a huge clue about where the damage might be.
Then comes one of the classic signs. Yeah, this is the one many of us picture when we think of a stroke, facial drooping. A simple request for the patient to smile or show their teeth can instantly reveal if there's weakness on one side, pointing right to an issue with the facial nerve.
Then they get into testing raw power. Can the patient hold their arms out against gravity? Can they push with their feet like they're hitting a gas pedal? They're looking for any imbalance, any asymmetry. A weakness on one side of the body is a huge red flag for a neurological deficit.
But it's not just about strength, right? It's also about control. A simple finger-to-nose test checks for something called ataxia, basically a lack of coordination. This tells them if the cerebellum, the brain's maestro for motor control and balance, has taken a hit. And here's where it gets really fascinating. The scale doesn't just ask, can the patient speak? No, it pinpoints the type of language problem. Is it receptive aphasia, an issue with understanding words? Or is it expressive aphasia, an issue with actually producing them? Two very different problems.
So, okay, we've covered understanding and forming words, but what about just the mechanics of speaking? To test for dysarthria, or slurred speech, a clinician might ask the patient to describe a really complex picture like this one. How clearly they can get the words out gives them another valuable piece of the puzzle.
All right, so now we're going to go a little deeper, because sometimes clinicians need to look for signs that go beyond the standard scale. Primitive, what they call pathological reflexes that can signal a really deep and significant brain injury.
I know, pathological reflexes sounds intense, but what are they? Well, think about it like this. They're reflexes that are totally normal in infants, but if they suddenly reappear in an adult, that's a major red flag. It often points to a problem with the upper motor neurons in the brain or spinal cord.
And the most famous of these, it's got to be the Babinski sign. Normally, in an adult, if you stroke the bottom of their foot, their toes should curl down. But if the big toe shoots up and the other toes fan out, that's a positive Babinski sign, and it's a crucial indicator that something's wrong in the central nervous system. And what's amazing is how simple this test is. I mean, it's just a quick, non-invasive, three-step process, but it can provide a massive amount of information about what's going on in the central nervous system. Another one of these key signs is something called clonus. If a quick stretch of the foot makes it start beating almost like a drum, rhythmically and on its own, that's clonus. It's a sign that the brain's normal braking system on our reflexes has been damaged.
Okay, so we've run through all these tests. Consciousness, eyes, speech, reflexes. Now what? How does all this information come together to form a real, concrete plan of action?
Well, it all gets tallied up. Every one of those 11 items gets a score, and they add up to a single number, somewhere between 0 and 42. And as you can see, that score directly correlates to how bad the stroke is, neatly categorizing it from minor all the way to severe.
But, and this is a really important but, a score of 0 doesn't mean you're in the clear. A patient can absolutely still have a stroke show up on a CT scan. A 0 just means the stroke hasn't produced any measurable symptoms, at least not on this particular scale.
And that one number? It's incredibly powerful. It gives the whole healthcare team a common language, so they're all on the same page. It helps them predict a patient's chances of recovery. And most critically, it guides those immediate, life-saving treatment decisions, like if someone is a good candidate for clot-busting drugs.
So when you step back and look at it, the NIH Stroke Scale is really a brilliant piece of clinical logic. It takes this chaotic, complex, frankly terrifying event inside the brain and translates it into a clear, actionable number. It gives you a rapid roadmap of the brain at its most vulnerable moment.
The elegance of this scale is that it finds a way to quantify the invisible. And it really makes you wonder, right? If we can create such a powerful system to measure a stroke in minutes, what other hidden conditions of the body and mind are we just on the cusp of being able to decode next?